Hi there. This video is an overview of the clinical reports for managing user needs and ACRs. Now, this is probably the most daunting looking folder, but actually, probably most of the reports won't have patients in, and I'll explain why as we go through. So first of all, there are again some letters to send from alerts on the patient home screen. Retrieve the patients, find the alert on the home screen, you click action and just follow the steps. Retrieve and save like normal. So this should be under nephrology. This one links to this report. So essentially what this report is doing is it's finding patients who perhaps should be under nephrology, renal, whatever you want to call it, due to various results. And the system thinks they're not under renal. Now, those patients may well actually be under renal, but you may not be coding those letters. So this report is looking at those patients, if you've got some in there, who've had some kind of letter in the last 14 months. You can break it down by the sender and the date and the letter type. And then that code 9N1M, I believe, is to record that they've been seen by nephrology. If I type it in properly, let's try that again. Wrong way around. 1M. Yeah, seen in a nephrology clinic. Now, we've been running this for some time, so right now we've got no patients in there. When you very first start using these reports, you may find quite chunky numbers like 50, say, patients. And before you task them all to GPs to look at, or a GP goes through this list, you might want to do this kind of process first. You may, and it's important when you do that, you do add the code backdated to the date of the letter. If you're not already, you might want to look at either scanning rules or what your scanning team are doing, but we'd recommend that you do code when people are seen in clinics. Certainly for this pathway and a few others, our systems look at that to go, okay, yeah, they're under nephrology, so we don't need to consider referring them. After a certain time frame, the fact that they've been referred years ago, if their results are still really bad, then they're going to flag up for review because they may need to be re-referred. So this is possibly a report that you might run at the start of rolling this out, but may not do regularly, particularly once you've got your kind of processes and things well established. Review reports, non-responders, again, up to you as a practice how you manage those. This is the only one for clinical review. If you want that to go directly to a GP appointment, we can configure it to do that. I wouldn't necessarily advise it because, in my experience, or talking to the GP who does it in our practice, A, patients are sometimes under nephrology, or B, there may be reasons why they're not appropriate, and you may not necessarily want an appointment to discuss that. So I think most practices will find it works best just to work straight off that report, either someone working through them or tasking them to GPs to review. Coding reviews, these categories are not as sort of important as perhaps some of the others. They're not essential, but useful. Again, you wouldn't expect many patients in these reports, but it's where for various reasons there seems to be a bit of a gap in kind of what's coded. These chunky sections then are for either updating CKD diagnoses or doing new diagnoses. Now, we've got no patients in them because we're using the auto-coding functionality. The biggest downside with that really is just that it won't code it as a major problem. So as a result, some practices prefer to do this manually. Again, when you start, you probably find quite a lot of patients in here. Once you've cleared the backlog, then it won't be a great deal. You may find the first year of running this, you've got more because you'll have patients who historically are having results that are being repeated and confirming diagnoses. But again, it starts to settle down. Similarly with the updated diagnoses, because it's updating an existing diagnosis, you're more likely to be happy for that to be auto-coded because you wouldn't necessarily be creating a problem heading for that. Again, up to you, but whilst there are a lot of reports here, certainly if you're using all the auto-coding, they want to be in there anyway, and the numbers will be fairly low. Prescribing review, So this is where there are medications to consider prescribing in light of recent results. We've got these going straight to an appointment, which is why they're zeros for us. Again, let us know if you want it configuring that way, or it can be done as a notes-based exercise in the first place. Comms Annex, again, we've got zeros because we've got them all automated, so those patients are effectively sat in this retrieve and save cohort. If you've got patients in there and you want to use the automated functions, let us know. Letters, again, can't be done in bulk can't be done automatically. So these are ones that do need to be sent. We've not included the satisfactory outcomes for letters. That's a kind of very much in the nice to do rather than most practices wouldn't write to patients to say results are fine just because of the cost and time and so on involved. And we'd be encouraging patients generally to look on the NHS app and so on to find that kind of information. But if you really want to do that and have that thing that'd be useful, then let us know. Happy to build that. So yeah, there's a lot of reports in here, but actually you should find the numbers fairly low, and it's a fairly light workload for admin running this part of the system. Thanks.